Hi, it's Rosie Dupont here. I see so many people talking about induction, so many women talking about induction, that they've been offered induction or they're considering induction, and they're just asking for advice on what's going on, and whether they should choose it or not. I thought I'd do a short series of videos looking at induction, looking at the difference between, looking at why induction is offered, what questions you should be asking if you're offered induction, the difference between induction and spontaneous labour, how to write an induction birth plan, and why this is important, and then look at other options like natural induction. So to start with, induction was introduced as part of the medicalisation of childbirth. There wasn't any research done as to its effectiveness or benefits. But it has just become an established part of the childbirth scene, if you like. More people are offered it than maybe it would be advisable for, and it does pose some risk both to mother and baby. What's important to think about though is that when you're offered induction, the reason for it is to mitigate the chances of the hospital having any legal action taken against it. So it tends not to consider the individual woman as to whether it's going to be of benefit to her and her circumstances, which is why it's really important that you know what it's all about, you understand how it works, you know what questions you need to ask. Importantly, you'll need to know where to find recent research on the benefits and risks opposed to waiting for spontaneous labour to happen or choosing to be induced. You need to make sure that the people who give you the information are really giving you proper facts and research-based evidence, and that they are giving you the real numbers. You know, so often you hear about there's a higher chance or a higher risk or a greater risk if you don't induce, but if you start to look and break down the numbers, you start to see that those higher instances are not so high, in fact, and so it might help for you to know those numbers when you're making your decision. So this series is going to be split into a couple of three different parts. Today we're going to look at the difference between spontaneous labour and induction, and what is involved in induction. Next week we'll look at the different things induction is offered for, and we'll look at the what those are, how often they happen, the benefits of induction as opposed to waiting, and the risks concerned with either option. Then we'll look at creating an induction plan, what questions you should be asking, how you need, if you choose to have an induction, then what questions and support you need to get from the medical practitioners, and what you need to do to prepare yourself for the induction so it is as positive experience as it can be. And then lastly we'll have a look at what's termed as natural methods of induction and the benefits and risks and effectiveness of those. So let's just have a look today at spontaneous versus induction. So spontaneous labour, let's have a look at what starts it first. So although we don't really know exactly what starts off labour, the scientific understanding at the moment is that it signals from the baby once they are developed enough to be able to survive outside in the outside world, and the baby sends a complex mix of hormone messages to the mother in order to initiate the contractions and labour. But before that, during the last weeks of pregnancy is when you start to get the laying down of the hormones that will start to allow the mother to bond and to produce milk. You get the levels of the natural pain-killing hormones in the mother rising so that she's ready for those. You get increased levels of oxytocin, which is what causes the contractions. And the oxytocins also create a calm and relaxed mind for the mother, so it enables her to surrender to the contractions in birth. Within the uterine walls, oxytocin receptors are laid down so that they can receive the oxytocin and the contractions can happen. For the baby, they start to lay down more fat so that they can have the energy for being born and for also suckling once they're born. Their brain develops enough to enable them to be able to breathe, to sleep, to nurse, and the lungs start to develop. The lungs finish developing, so they are able to inflate, ready for breathing those first few breaths. The baby also receives antibodies from the mothers to be able to help them fight any infections. A complex mix of hormones is produced that gradually thin out the cervix so it's able to open safely to allow the baby to descend. Contractions start off very, very slowly, build up over a matter of hours. The pain-killing opiates that the body naturally make increase, so the mother's able to deal with the pain of the contractions. And the contractions also cause the baby to start to move into a position that's good for them to birth, so they can move around and down into the pelvis. The oxytocin levels increase, and they, as we just said, they allow they cause the uterine muscles to contract. It also helps the mother to have the mother's bonding instinct to happen at the end of birth once the baby's born. This oxytocin is regulated by the baby, by the uterus, by the emotions of the mother, and by the environment she's in. And this is why contractions can slow down or get less or more intense, or sometimes even stop, to allow the mother and baby to rest. If the baby's not in the right position, it gives the baby time to turn and move as they need to birth. And if contractions have been going on for a long while, they do tend to stop to allow the mother and the baby to rest and relax. Sometimes the mother can even get some sleep. So the amniotic fluid also plays an important part in the birthing technique. It helps to cushion the baby against the contraction, so the baby doesn't get stressed by too tighter contractions. And it also cushions the umbilical cord, so the oxygen for the baby, the nutrients and oxygen via the placenta is not inhibited by the contractions as well. As the labour progresses, a surge of adrenaline enters the body. This is what's commonly known as transition, and the adrenaline is helped with helps the fetal ejection release to push the baby out, and it also prepares the mother to be able to look after her baby once he or she is born. There's a point where the baby's head is crowned, that there's usually a lull in contractions to allow the baby to finish turning so their shoulders can be born, and also for the baby to take their first breaths and for the mother to have a rest before that final surge to birth the baby. It's this surge of hormones towards the end that helps the mother feel euphoric and empowered at the end of birth. It helps to get the baby alert and ready to crawl up towards the breast and latch on. And also those hormones also cause the bonding instinct between mother and baby, so the eye contact and the mother being able to gaze and get to know her baby from the looks and the smell and the touch and the feel of her baby, and even the kissing. It helps with the taste of a baby. So it's this wonderful mix of hormones and communication, that silent communication between mother and baby to allow that birth to happen. So with induced birth and induction, obviously there isn't this surge of hormones. So there are 3 steps to induction. The first is ripening the cervix. This allows it to thin and open to allow step 2 to happen, which is breaking the waters. And the third part is inducing the contractions. So the first step is the cervix being assessed, and it's assessed against something called the Bishop's score. And although this isn't very accurate, it does help to decide the next steps to be taken. And what this Bishop's score is looking at is the thickness of the cervix, how long it is, where it's positioned within the vagina, that's how low it is, and also how much it's moved forward. And it also looks at how soft it is and how open it is. And with the higher the score, the more favourable your cervix is for induction. So the next part is what would be the stretch and sweep, which is where the midwife will give you a vaginal exam and use her fingers to sweep between the amniotic sac and the cervix. By doing that, it helps to get the body to release its own prostaglandins. Quite often this is offered to women at a certain date, sort of 38, 39 weeks, just as it's mentioned as kind of something quite casual. Would you like a stretch and sweep? But it's important to know that it is an intervention, and it is the first step of an induction. It's not a gentle procedure. It has to be quite it has to produce quite a lot of discomfort in order for the body to start to produce the prostaglandins. The side effects can be pain, they can be bleeding. It can also cause contractions to start that are irregular and can go on for several days before established labour happens. There is also a small chance the amniotic sac can be ruptured, which will cause the waters to break, which then moves you on very quickly towards more interventions. There's only a certain amount of time between the waters breaking and when hospitals will want the baby to be born. And it also can cause prolonged pre-labour, which are the contractions that happen up, it can be days before established labour happens, and it can be exhausting and frustrating and bring on more interventions a lot quicker. As I say, the effectiveness, it's hard to tell because you don't know which women will have gone into spontaneous labour anyway, and the numbers are looking at 1 in 8 women go into spontaneous labour after a stretch and sweep. If the stretch and sweep doesn't work, and the next stage is to introduce a synthetic prostaglandin, and this is done either via gel or a pessary, and the gel is put near the cervix to encourage that thinning and opening. It will have to be done in hospital because both you and your baby will need to be closely monitored. You will have your blood pressure and heart rate monitored, and your contractions will be monitored. Your baby's heart rate will need to be monitored, and that's usually done via CTG, which is something that it's like a little box that you wear on your stomach and wired up to a machine that checks their heart rate. The baby's heart rate will be looked at for the first 30 minutes, and then it will be reassessed again after 4 hours. If you've had gel, you will then have your cervix reassessed after 6 hours, and if you've had the pessary, it'll be reassessed after 12 hours. If there's no change, then that procedure starts again. The risks to this are it can be a sharp pain around the cervix. It can cause uncomfortable uterine cramps, and it can feel a bit stingy. It feels particularly if you use a gel, it can feel quite stingy around the cervix as well. Less common side effects are nausea and vomiting and fever and diarrhea. And very rarely it can cause hyperstimulation of the uterus. This is very fast, very painful contractions. If this does happen, they will try and wash out the prostaglandin, they'll remove the pessary, wash out the gel. But if the contractions don't stop, then you will need a cesarean, because it will be too much for both you and your baby, and it could lead to uterine rupture. But again, I say that's very rare, but it's still something to consider. If you are at risk of hyperstimulation of the uterus, or these things haven't worked, then the next thing to look at is mechanical. And this is when a balloon is inserted into the vagina and into between the cervix and the amniotic sac. And then it's inserted, deflated, and then it's pumped up with saline solution. It creates pressure on the cervix to stimulate the prostaglandin and also to stimulate oxytocin. And again, this after you've had this done, you will have your cervix reassessed after 12 hours. There is a risk of discomfort and cramping, although it's less than synthetic prostaglandin. The other risk is obviously it may break the amniotic sac, and it might also push the baby up out of the pelvis, which means that the baby is less favourable to be born. It's not in the right position, and it could allow the umbilical cord to drop down and be born before the baby, and that can cause some complications at the end of birth too. Next stage is, so once your cervix is ripe and open enough, the next stage is breaking the waters, and that's done with an amni hook. It's like a very large crochet hook, and it's inserted up the vagina and used to tear a hole in the amniotic sac, and the midwife will then put her fingers up your vagina and use her fingers to open the sac further. Now there's no nerves in the amniotic sac, so this isn't painful at all. Once the water's released, then you can move on to stimulating contractions. And it's useful to know that many women go into spontaneous labour after this happens, so it's well worth waiting a while before you do anything else. The risks are that it's uncomfortable because of the amniotic hook, the amni hook inside the vagina, and the cervix are moving around. There is a possible bleeding of the cervix. Occasionally the baby's head will be scratched, and there will be an increased risk of infection, particularly if you are having lots of vaginal exams. So that brings us to stage 3, which is inducing contractions. So you remember how in spontaneous labour there's a huge mix of hormones all coming into play to get the body working and talking to the baby. Including oxytocin. So to induce contractions, it's just a synthetic version of oxytocin, which can work with the oxytocin receptors on the uterus wall that will encourage contractions. However, there are a couple of differences with the synthetic oxytocin, and which is called syntocinon, which I'm only going to say once because I really stumble over that, is that it can't be, because it's given by intravenous drip, it is designed to keep strong, steady contractions all the way through. So this is where it becomes more painful, because with a spontaneous labour, you are having this gradual build-up of the contractions. You are having the build-up and release of all the hormones that help with pain killing, with help keeping you calm, and just getting the body to work so beautifully and streamlined. So a natural oxytocin is regulated by the baby, the uterus, the mother's emotions, and what's happening in the outside environment. So this way the monitoring is so important of the mother and the baby, because the baby can't send a message to slow or lessen the intensity, or even stop the contractions as need be if they need to move into a different position, or if mother and baby are feeling tired. In a spontaneous labour, the contractions can even stop to allow the mother and the baby to sleep and rest before the next lot of contractions happen. And this doesn't happen in induction. The contractions are just strong and steady and don't change. Oxytocin can, this synthetic oxytocin can also pass into your baby's brain, and it can inhibit the baby's natural release of oxytocin, which can lead to the bonding instinct, so the making eye contact and nursing. It can inhibit that, not stop it, but it can mean that it takes a little bit longer and you need to have a lot more skin to skin waiting time. And obviously it does not going into the mother's brain, it's not causing the mother to stay calm and to have that relaxed state. And this is where if you are having an induction, a plan is so useful, because you can create those outside environments for yourself so you can get into that calm state of mind. So the synthetic oxytocin is started very slowly because every woman reacts differently to it. And then it is slowly increased every half hour until you're getting 3 or 4 contractions every 10 minutes. Once that contraction pattern is happening, some women will carry on in labour and won't need any more of the synthetic oxytocin. Some women, however, that will need to be carried on right through labour. So the risks with having the synthetic oxytocin is, as I said, it's delivered by IV via a cannula, which is inserted into the hand or the wrist. And you will have the CTG monitors attached to you, usually by a belt around your stomach. So this can inhibit how much you can move around during labour. It will likely mean you couldn't have a water birth if that's something that you wanted. However, you can get both waterproof and wireless CTG monitors, so which gives you more chance to move around and possibly get into a water birth. So that is something to think about and to ask about. You also make sure that you have the cannula inserted in your less dominant hand and in the wrist rather than the hand. That gives you more mobility there as well. It is likely you're going to need more vaginal exams for monitoring during this process. And occasionally this fails. It may be that the uterus just hasn't laid down those oxytocin receptors. So it doesn't matter that you're having the oxytocin in, the receptors just aren't there to have the contractions, to create the contractions. And in that case, a cesarean will be offered. It can take longer, using the contractions this way, and because they don't slow down and stop, you may find that you'll need something like an epidural to eliminate the pain, so you can just rest. So many women have very successful and very, very positive inductions, and some of them don't even see any difference between an induction and a spontaneous birth. However, many women do have very traumatic inductions, and it does affect them with regards to how they see their birth, how they bond with their baby, whether they can manage to breastfeed or not, and it increases the risks of things like postpartum depression and low self-esteem feelings. Because induction is such a standard part of childbirth in the medical Western world, it is offered quite matter-of-factly, and often you might be told that you're having an induction rather than being offered, and rather than it being something that you find all the information about and you make that informed decision on whether you want to do it or not. And as I said, sometimes the information isn't given as unbiasedly as it could be, and so you might not be in receipt of all the information to be able to make an an informed decision, especially at the end of pregnancy when you're getting more into the zone of preparing for labour. It's very difficult to make quick decisions, and if you're told that this is better for your baby, then of course you're going to do it. In hindsight, if you've been given the knowledge, you might have decided to wait. So in the next part, we'll look at the different reasons that you're going to be offered an induction, and how to weigh up the risks and benefits of waiting over the risks and benefits of induction for each different scenario. So I hope that's been helpful. If you have any questions or anything you would like to share, then please share in the comments. Otherwise, do take care, and I will see you next week.